Vicky Barry, convener of the network. We begin by acknowledging the traditional custodians on the land on which most of us are meeting today, the Whadjuk people of the Noongar Nation, and pay homage to elders past and present. Please note that the webinar is being recorded and will be distributed to everyone who registered post-event. Only the presenters should be visible and audible, but it looks like we all are. So if you could turn off your cameras and your audio, if you are not on the panel, that would be appreciated. And for specific questions arising from the subject matter, please use the chat function and we'll monitor that as we go. And at the end of the discussion, we'll field them to the panel members and get them to address those queries accordingly. So let's get started. The webinar will focus on polypharmacy, which is a clinical challenge because of the complex balance between managing disease and avoiding medication-related problems. We will explore best practice management by following and unpacking the journey of Glenda Parkin, who lived with posterior cortical atrophy, a neurodegenerative syndrome dominated by the deterioration of visual function. Over time, Glenda became functionally blind, and for 13 years, she was supported by her husband and care partner, Bronte Parkin. Bronte is a dementia advocate with a special interest in medication management and the importance of informed consent. He contributed to the development of psychotropic medicines and cognitive disability or impairment, clinical care standard published by the Australian Commission on Safety and Quality in Healthcare, and he presented on polypharmacy and deprescribing in dementia care at the National Medicine Symposium in 2004. And today we're really privileged to have a stellar cast of panel members who will provide their perspectives as the journey unfolds. And it's my pleasure to welcome Dr. Alyssa Campbell, who is a geriatrician and palliative care physician, consulting in acute geriatric medicine at Sir Charles Gardner Hospital. She's president of the Palliative Care WA and chair of the ANZ Society of Palliative Medicine Specialist Interest Group in Palliative Care for Older People. We also have Dr. Andrew Stafford, who is a pharmacist and senior lecturer at Curtin Medical School with experience in community pharmacy, aged care and academia, and his primary interests involve ways to optimise medication use, particularly with a focus on quality of life and patient-centred care, dementia training and clinical geriatrics. Dr. Craig Berg is a GP with a special interest in geriatric medicine and palliative care. He has dedicated his career to caring for patients in residential care and is renowned for providing compassionate and ongoing support to his patients, their families and to staff at care facilities. And now to introduce Sheridan Reid, who is a valued member of the Yodwa Impact Network, who will moderate the session. She has a background in nursing and is an academic researcher and lecturer at Murdoch University. Over to you, Sheridan.
Thank you very much, Vicky, and welcome everybody to the webinar this afternoon. I thought to get us started, I would hand over to you, Andrew. I thought it would be really good if we could just talk to the audience a little bit about polypharmacy, because that's a term we hear frequently in the context of medication management. And what does that mean when we're supporting people with dementia?
Thanks, Sheridan. So polypharmacy is a construct we've been talking about for decades, and many decades ago when I first started practicing in the area, polypharmacy was typically thought of as people using 5 or more medicines, and people who were using 10 or more medicines we thought were in a particular high class of polypharmacy, and we called that hyperpolypharmacy, but we seem to be moving away from that terminology a little bit. But regardless, the term's generally associated with negative connotations because it's been associated with a number of negative health outcomes, particularly for older people, but also for those who are younger people living with dementia as well. Depending upon what you read, it's been associated with things like an increased risk of falls, frailty, and even an increased risk of mortality. And it's thought that these occur because of a number of different factors. So because of the sheer number of medicines that people who are exposed to polypharmacy are taking, there's an increased risk of interactions both between the different medicines that they're using, but also the medicines and the other medical conditions that they have. Obviously, the more medicines you take, the higher the burden of just managing those medicines. So ultimately, medicines only work when you take them. And so if you are having difficulty in taking them, you tend not to get the benefits from the medicines that you might expect. So that becomes a bigger issue with polypharmacy. And of course, just because of the sheer number of medicines that you're using, there's an increased risk of adverse effects associated with them. I can keep going if you like, but I know that Vicky said we have to be succinct.
She did.
So if you want to cut me off, go for it.
No, I was actually just going to ask you, how is it monitored? How do we monitor polypharmacy?
I mean, the only place where we currently monitor it rigidly is actually in residential care, and they have a clinical indicator of polypharmacy. And you might remember that I said we used to think of polypharmacy as being 5 or more medicines, but the Aged Care Quality and Safety Commission consider 9 or more medicines to fit their definition of polypharmacy. But as clinicians, you really need to move away from thinking about polypharmacy in terms of just numbers of medicines, because a lot of the time, if we have patients who have complex comorbidities, so lots of different medical conditions, polypharmacy can actually be a good thing, because we have lots of different treatments which are effective and safe when used together. And so that's known as rational polypharmacy. What we need to be mindful of is inappropriate or problematic polypharmacy. And that's when we're not monitoring the medicines a person is using, and they're just accumulating and increasing the risk of causing adverse effects. And I think we're going to see some issues with problematic polypharmacy with psychotropic medicines later on in the case study from today.
Yes, you certainly will. Very complex matters we're confronted with. Bronte, I might now pass over to you, and if you could introduce us to the scenario or the scenario in which you cared for Glenda. And thank you very much for coming on board with the webinar today and sharing your experiences. Tell me a little bit about the time Glenda was diagnosed with dementia. What was going on around that time in your life and hers?
Hello, everyone. Well, Glenda was a full-time worker. She was a high-functioning private school principal when she was diagnosed, it took about 6 months or 7 months before she got the definitive diagnosis after initial tests. And as you alluded, but didn't mention the actual specific disease that she had, she was diagnosed with posterior cortical atrophy, which is otherwise known as the visual variant of Alzheimer's disease. So she was age 56. And so this was a sudden, obviously a shock to her and our family. And so she concluded working in that same year and lived for 13 years, as you mentioned, 10 years at home here. She was cared for by me mainly, and 3 years in residential aged care. And she passed away 2 years ago. So pretty much that's in a nutshell, what her diagnosis was.
Yeah, thank you. And when she was first diagnosed, was she commenced on any medication at all?
Yes. So on the very day that the diagnosis was delivered, I was handed, we were handed two scripts, one for an antidepressant, and the other, the cholinesterase inhibitor, known as Reminol or galantamine. I asked the specialist what these were for. He said that the antidepressant was a low dose. It was a mood leveler, because her mood would change. Because this is the very point of us confronting dementia for the very first time. So we took it at face value that these were the right things to be prescribing. And the Reminol was typical of the other drug, more commonly known, I think, is it Aricept, for perhaps slowing down the rate of progression of dementia. So we walked out with the 2 scripts, and that's where her journey with medication started.
Yeah, so there wasn't sort of any discussion or around benefits versus risks or anything like that in the process?
No, I've said that before in past presentations. The issue of consent was never raised, or if it was alluded to, it was inferred or implied, whatever term you want to use. And of course, we being complete novices in this space, just assumed that the specialist was making the best decision in her interests.
Yeah, that's understandable. And what about sort of medication reviews? When did they occur? Was there any kind of discussion around a plan for like how long she might be on the medication or when the medication might be reduced?
Not really. I mean, for 10 years, she had 6 monthly visits with the specialist. She had no interaction with her GP. I know that in the preliminary preparation for this seminar, you asked about that. The reason for why she had no interaction with the GP was the GP changed, and she had no real need to visit her GP, largely. So there was no regular visit or interaction with the GP. It was purely with the specialist. And all of those 10 years, there was only one occasion when the dose rate of Reminol was increased slightly. I can't remember the exact reason why it was increased, but it made her nauseous. And so that was just reduced back to where it was, and it remained that way for a decade. The antidepressant stayed at the same dose rate as well. Whether you call it a review, I suppose it was a kind of tacit review. Each 6 months, the specialist looked at it, and that was it. Renewed the script, and we walked out again.
Right. Okay. No discussion around what might have been going on at home or anything like that?
No, I've said before, I think my issue with medical practitioners is if the patient's not displaying symptoms or behaviour right there and then, especially with dementia, it's a diagnosis purely on the basis of reported observations, usually by the care partner. And whether that's the only way possible or is it accurate, who knows? That's a question to ask.
Well, that's a good time for us, I think, to head to you, Craig, if that's okay. I was just wondering what your perspective was on this and if you would have taken a different approach at all.
Oh, yeah, thanks very much. And thanks, Bronte. It sounds like a pretty tough journey, even this far down the track. Yeah, look, I guess, I hope, and in a perfect world, communication would be a lot better. And I guess me being an aged care specific GP, I'd probably try and have reversed that balance of medical involvement. So it's pretty normal to only see a specialist once every 6 months or 12 months in this case. I guess what we hope is that a GP is the person you'd see more frequently, often every couple of weeks or month if you're fairly stable and if you know them. And I guess, again, as I say, I have an aged care practice, so I see my patients fairly frequently. And obviously we hopefully, in a perfect world, know our patients well. So some of those subtle changes in terms of progression of dementia and whether the medications are working is something we would know a little bit better. But I appreciate that wasn't the case in this situation. And so similarly with informed consent, we often try to fill out some of the details from those initial consults with the specialist because they're sometimes short of time and talk about the pros and cons of the medicine. I guess, as a general rule, my thought is that most of these medications only work, at best 20% of the time. I mean, the cholinesterase inhibitors are pretty limited in their benefit. So again, we try and explain that and watch how they go. And similarly with antidepressants, it's not uncommon to try an antidepressant because depression is a very common thing that happens along with dementia, and it can be very hard to know for sure, because there's some realistic life depression in being faced with that diagnosis and a difficulty in expressing it. So I think there probably is very few patients of mine with dementia who haven't tried an antidepressant somewhere along the way. But again, I think, we would like to be monitoring it, seeing if it has an effect, sometimes trying off it to see if there's any positive or negative effect before deciding if they need it. So I guess, in a perfect world, being a GP, we'd like to be central in a patient's care and have that relationship with people over time. But I appreciate that didn't happen here.
I think you raise a good point there, Craig, around how often you might receive a visit from the person and their care partner, and having that familiarity with what's going on at home for them and the change in the symptoms. I think you mentioned subtle type symptoms. I think that would make a considerable difference, certainly, to Bronte's situation. Andrew, I was just wondering your thoughts on this now. Anything in terms of perhaps best practice guidelines that you might be able to refer to?
I'm trying to remember the name of the exact document. It's something along the lines of the Clinical Practice Guidelines for people living with dementia in residential aged care. So it's a University of Monash-led project that came out about 3 or 4 years ago that looked at exactly this type of issue. And I can only say that it was very, very well summarised by Craig just a couple of minutes ago in terms of the establishing that the benefits of the medications aren't always going to be achieved. More often than not, in most people, they aren't going to see the anticipated benefit. So it's really important at the outset to establish that you are trying to treat a particular symptom or group of symptoms whenever you're using psychotropic medications in this sort of circumstance, and making sure that the person is actually getting benefit. Or even if they do get benefit, the fact that the treatment is not likely to be lifelong. And it sort of surprises me and somewhat disheartens me that in Bronte's wife's journey, it took such a long time for a review process to actually be done on those medications. And it is covered in those guidelines very, very explicitly about the need to review regularly and hopefully withdraw if you can.
Thank you, Andrew. Bronte, if we can just now fast forward 9 years, Glenda starts to experience high levels of anxiety, agitation, restlessness, aggression, also sleeplessness, and delusions. If you can provide any sort of more context around what was going on at this stage of your lives. And I understand it's at this point she's prescribed 2 psychotropic medications, lorazepam, a sedative, and quetiapine, an antipsychotic, and she does continue on the antidepressant. Tell me a little bit more about what was going on at this time in your lives.
Yeah, did you say 5 years or 9 years?
9.
9, yes, it was 9 years. So yes, so this particular disease trajectory was, plateaued pretty much across those 9 years, and then in that final year, it was as if she started to fall off a cliff. So those symptoms that you mentioned became more obvious. This unfortunately also coincided with the onset of COVID in our community. So the interaction with the specialist was by telephone. So I described these symptoms in my, naive or amateurish way. He put the labels on them, and then was concerned about that in a holistic way, I guess, and said that, well, there are 2 things that can be done when there are these periodic displays of deteriorating behaviour, which I found quite troubling and unnerving for me in terms of my management of Glenda. Was when lorazepam, I used that sort of like it was given on demand or whatever the word is, whenever I thought it was necessary. It wasn't a regular thing, but her behaviour went in sort of cycles. About every 6 to 8 hours, this sort of behaviour came about. And then in addition to that was the quetiapine, which he said this was a low dose and that would assist in her sleeplessness. And so so she was on those two medications for about 2 weeks. I made another call as timetabled to explain again what was happening, and sleeplessness was still problematic. So the dose rate was doubled, but it was still considered to be a low dose. Now, during that time, she started to show what we now know as a dyskinesia, a leg movement disorder. She had some restless legs and muscle twitching. She had a couple of near-miss falls around the house and outside, once falling into the shallow end of our swimming pool, fortunately. And then the fateful one was a severe fall inside our house on the timber floor, which resulted in her fractured pubic rami bones. And so that was if you like, the trajectory of the crisis that occurred. Do you want me to go on a bit?
Well, she was then transferred to hospital, I imagine. How was that?
Yes, I called an ambulance and she was taken immediately to hospital, where the medications that I had were taken in, and the consulting psychiatrist at that hospital looked at those and reviewed the medications, and the next day explained to me that in his opinion, it was the quetiapine that had caused the imbalance and was probably causing this leg movement disorder. Now, by this time, I have to say that the leg movement disorder was manifested itself in a rather unusual way. So here we've got a woman lying flat on the bed with, a fractured pelvis, and she is lifting both legs, despite the fracture, lifting both legs up into the air and waving them from one side of the bed to the other side of the bed. So precautions had to be made to ensure her safety. So bed rails and things had to be put in place. And so she had no control. They were completely involuntary movements. And the care staff, we had a full-time carer in the room all the time, or on rotation. And all the hospital staff used to laugh and quiz me about why she was doing this, and I said I have no idea. They wondered whether she had been a ballerina or a gymnast in a past life. It wasn't the case, and so the psychiatrist determined that this really bizarre behaviour was the result of the quetiapine creating this leg, had triggered this dyskinesia, as it was referred to. So there was he then started to from that day one, deprescribed that dose back from 125 milligrams down to 25, and said it would be done progressively over the period of her hospitalization, which was a 5-week period. Now, during that period, of course, she was unable to walk, obviously, and all efforts to get her to walk by the physiotherapists at the hospital failed. And the explanation for that was, of course, the dementia had reached the point where there was just no, communication between her brain and her leg muscles. So they basically said, well, she'll probably never walk again, which was the case. And that triggered the consideration of what's the next step? Is she going to come home, or is she going to be going to aged care? So that's why I call it a crisis. What would I do? What would the family want me to do, and so on. So we made the decision that she was ready for aged care. I suppose this is where the carer's role comes into play then, of how many years can a carer put up with caring for someone for such a long time.
You raise a good point there about the quetiapine was deprescribed. Yep. And I'm going to hand over to Andrew in a minute to kind of brief us a little bit more on that process. But just before we do, Bronte, what about pain management while Glenda was in the hospital? What did that look like? Can you recall at all?
Oh, sorry, you just dropped out then. You asked the question to me?
Yes, that's okay.
I think those there's some medications listed here. There's oxycodone, paracetamol, ketamine wafers, and valproate sodium were the additional medications that the psychiatrist introduced whilst she was in hospital. So I assume some of those are to do with pain.
Yes, yes. Andrew, could you tell us a little bit about the deprescribing process that was undertaken with Glenda and her quetiapine when the doctor noted that to be causing the dyskinesia?
I don't know the specifics of that particular case because I wasn't involved with it, but I can talk about deprescribing in general.
That would be good. Yes, thank you.
So deprescribing is essentially it's a person-centered intervention where we're looking at ceasing or withdrawing medicines that are no longer achieving a person's goals of care, if you like. In this case, it's fairly straightforward to make the argument that we shouldn't be using the quetiapine. Number one, it didn't seem to be achieving the objectives. Bronte described that it was commenced for insomnia. It didn't work, so they doubled the dose. It still wasn't working. And so how much do you have to give before you decide that something isn't going to work? Bronte, I think, was assured that it was a low dose, but in this sort of circumstance, it's getting up there in terms of what we would probably be using in that sort of situation. So when you have a situation that a medicine's not working like that, it becomes an easier decision to deprescribe, and it becomes even more straightforward when there's signs of an adverse effect, which are in this case very, very significant and absolutely devastating for the patient. The issue with deprescribing becomes, what if there is no evidence that there are adverse effects or it's causing any sort of harm? And I see it a lot in my own practice where somebody is commenced on, say, a low dose of quetiapine for a behavior related to dementia. And it may be beneficial or it may not, but there's no evidence of harm. And so the decision to stop or to deprescribe the quetiapine or the antipsychotic at that point becomes a lot harder because there's a fear almost that the symptoms for which the medicine was prescribed may amplify when the antipsychotic is ceased. So there tends to be a little bit of inertia in those situations in terms of deprescribing. There's also a lack of clinician awareness. Sometimes you find that clinicians don't know that certain medicines can be stopped without causing harm. And certainly in the last 5 years or so, there's been a lot of research done into deprescribing, and we have some fairly good data on certain medicines that can be ceased without any sort of adverse effect in the short term. Sometimes it's hard to have those conversations with people as well. And so that lack of self-efficacy can influence whether something is deprescribed. And there's also a big push by patients as well, because the number of times I've spoken to patients and they're taking something which could potentially be deprescribed, but they recall a conversation some many months or years ago when it was commenced that they were told they will be taking this for the rest of their lives. And so trying to back off on some of those established norms can be can make the deprescribing process a little bit difficult. But we do know that most patients are hypothetically willing to at least have a conversation about deprescribing. And that's not just the patients themselves, but also care partners, as Bronte once was.
Yeah. And the process takes time itself, doesn't it? The process itself in order to deprescribe the medication.
Absolutely. And you never really want to do more than one at a time. And so if a person does have polypharmacy, like we were talking about at the start of the conversation here, it's a bit nuanced as to which one you decide to stop first, because the last thing you want to do is stop several medicines and have a symptom appear or potentially an adverse effect occur because of the deprescribing, because which one of the 6 medicines that you ceased actually was causing the benefit, or the cessation is causing the harm.
Yep. Thank you. Now, Alyssa, I haven't heard from you as yet, but I wondered, as a consultant geriatrician in an acute care hospital setting, what are your thoughts on this scenario as it stands at the moment? How would you manage the situation, and And what's your perspective? What would you be giving consideration to?
With any, I guess, deprescribing or prescribing decision, we really should be, as Andrew said, looking at what are the goals of treatment, what are the values and wishes of the patient, and supporting them to be involved in that decision making, and certainly involving the family. And that's not only for these sort of psychotropic medicines, but also for things like cholesterol medicines, diabetes management, that sort of thing as well. So in this case, in the acute setting, it's partly about finding out as much information as possible about the medications, when were they started, why were they started, what was the response, and often that does come from the care partner, the family. The GP is also a really important source of information in that scenario, because obviously we don't want to deprescribe something and cause more harm. In an emergency situation, obviously, we would if we thought there was a very obvious side effect like the dyskinesia. And as you mentioned, it can take time as well. And it's about explaining that to the patient, to the family, that we can't stop everything all at once. It's about gradually doing it, and monitoring for an exacerbation of, the symptoms that it's treating. And whether that can be done if it needs to be done in a hospital setting, or it can be done safely at home or in a residential aged care setting, again, will depend very much on what the medication is and what the side effects are. We'll also have a big consideration of non-pharmacological factors. So what has been contributing to the, for example, aggression and agitation? Is it all medication related? Are there other factors at play like pain, urinary retention, constipation, infections, all those sorts of things, and reversing as many of those as we can as well.
And do you find yourself in a situation of calling on a family meeting to have these discussions and weighing up benefits and risks, or does it tend to just be the care partner? What does that look like?
It depends from person to person who's involved in their care. So I'm based in the emergency department, so we will try to get in contact with family on the phone as early as possible. Sometimes they can't always come in that quickly. If they're there at the bedside, that's incredible. Obviously, Bronte mentioned during the pandemic where that was less available. I know we've talked about pain, and certainly getting that, what we call collateral history, from family members, care partners who know that person best. They know their history of pain, but also know what they might look like when they're in pain. Are they grimacing? Are they holding themselves stiff? Do they tend to go off their food? Those sorts of factors in someone that can't communicate themselves with words that they're in pain at the time.
And in the scenario right now where Glenda is being transferred to a residential care facility, what does that transition process look like for you? What sorts of things are you thinking about?
Unfortunately, it's often suboptimal. Importantly, we want an accurate medication list of also what changes have been made during the hospital admission, and that's difficult as often the doctor writing that discharge letter wasn't involved in the person's care. I might not know why those changes were made, so if we get a pharmacist involved in that communication at discharge, that's really helpful. Educating the patient and the family, although at the transition to residential care, again, that's often an overwhelming time when there's a lot of new information, not just medication changes. GP involvement is really key. If we're very lucky, we have someone like Dr. Berg, but unfortunately, in a lot of cases, people might lose their usual GP when they go into residential care if their usual GP that they've had for many years doesn't work in that facility. And also often in that transition from hospital into residential care, there can be more than one transition throughout that process. So there's a lot of sort of care awaiting placement or transition care beds, moves to different sort of secondary hospitals and things. And at each of those transitions, there's a risk of this communication being lost. So really it's family, GP, it's all about communication. And then in terms of once going into residential care, it's a bit of a postcode lottery as to what services are available at different facilities, but we have, older adult mental health services, Dementia Support Australia, which is available across the country. There's various geriatrician or palliative care specialist services as well.
That's really good. Thank you. Lots to consider. Bronte, I think this is timely, if I can head to you now. Glenda endures 5 weeks of recovery in hospital, becomes bedfast and complicated, as we know, by the dyskinesia. As we know, she's non-verbal, and she's transfers to the residential care facility where there is a shift to non-pharmacological interventions to manage her behaviour and to keep her engaged. Tell me a little bit about this scenario and how it all unfolded, Bronte.
Okay, well, to begin with, the dyskinesia, of course, continued. So this was very problematic for the aged care facility. They had never experienced anything like this ever before. So they were fully prepared, of course, for her admission. And they were very risk averse at not moving her from her bed for the first few months, which was quite distressing for me. So carrying over during that period of time, initially in the aged care facility, I continued the practice which had been commenced at the hospital to introduce what we'll call music therapy, because Glenda, with her functional blindness, could basically only accept oral input, no visual input from anything, because that's the nature of that disease. And so she was well attuned to listening to music. And so the basis of her non-pharmacological treatment, if you like, was, music therapy, put it that way, which we set up in the residential care facility. Now, during this time, for the first few months, she was, of course, bedridden, and it wasn't until the care manager changed where there was confidence to move her into a nursing chair, a Regency chair, because this leg movement disorder continued for, I think, about 5 more months. So this was the remnant effect of that antipsychotic drug in such a small dose. So, of course, not being able to use physical restraints, even in a chair. She had multiple cushions around her to try to keep her within the chair, because I insisted on her leaving her room, because I just thought it was so despairing to see my wife lying flat on her back, staring at the ceiling, no social interaction, no visual interaction with anyone, because she couldn't. So once she got into a chair, she was then able to be, moved outside. Fortunately, she was in a place near the ocean. She could smell the salt air, and so the environmental shift was important. So, moving from inside to outside, outside to inside, if her behaviour changed, and listening to music and so on were the non-pharmacological, factors.
And I understand you were quite instrumental in assisting the facility, Bronte, in developing the behaviour support plans. Is that correct?
Well, going back all those years now, of course, I don't know behaviour support plans, whether they were actually described as such, 15 years ago. Sorry, not, that was 5 years ago, sorry. And certainly there was a care plan in place, but I did insist and work with the care staff and the care manager to ensure that they knew exactly what I wanted in terms of listening to YouTube music channels, which were available through the television in the room. We documented all of that. I had notes and instructions on the side of the television as for the care staff to be able to know how to operate things to get the music going, and that's basically all they had to do. Plus, also, know that when she was she was a fairly gentle sort of person, and her behaviour wasn't extreme, but she did get agitated at times, and I suggested that that's when she needed to have her environment changed. She was sick of listening to music on the communal television in the lounging area. Move her outside onto a veranda and let her hear the waves of the ocean or the smell of the salt air or something. So they became incorporated into that. So that was through my direction of that. It wasn't anything that externally they had sought advice on. It was something that I insisted on.
Oh, this is good advice. And I'm just conscious of time and keen to kind of keep things moving. Craig, just quickly, much of your practice is spent in care facilities, working with clinical staff and caring and supporting residents. What's your thoughts here, and what approach do you take to assume mindful medicine and best outcomes for residents in this setting?
I think actually, if we go beyond the case at hand and look in general terms, I actually think some of this is easier and a lot better structured in residential aged care facilities. Certainly as a GP, I think one of the good things coming out of the Aged Care Royal Commission is sort of strict standards about us reviewing psychotropic medications. And so, speaking previously about the lack of reviews, we're sort of forced to review every 3 months at a minimum. And to deprescribe or to have a directive to deprescribe antipsychotics. So certainly the only antipsychotic we're officially allowed to use for dementia behaviours is risperidone. And we're only allowed to prescribe that for 12 weeks officially. And then we basically have to stop it or be seen to be trying to stop it. So I guess at every facility I visit, every 12 weeks, we have to do a psychotropic review to try to reduce medication. So I guess it's nice to have that structure. And similarly, in terms of family communication, we sort of have, as previously said, it's a very tumultuous time. So I usually don't change anything in the first 2 to 4 weeks, but then sit down and have a family meeting. And then we obviously have our regular reviews thereafter and arranged pharmacy reviews. So I actually think, again, one good thing of all these sometimes frustrating administrative burdens is that it really makes sure that we do follow up psychotropic reviews. In terms of general terms, yeah, we have obviously over the 25 years I've been going a strong direction to reduce psychotropic prescribing in advancing dementia. I think it generally is a phase. So over the course of someone's average 7 to 10 years of dementia, they'll often have a 6 to 12 month period where they have a lot of agitation and need to be on something for a period of months. And then invariably they come through that phase in their brain sort of development and they don't need to be on it anymore. So it's very common or not very common, but the patients who do need to be on medications, I often find it's a phasic thing. And so they go on it for a period of time, come off it, and then may have some other event a couple of years down the track where they need to go on something again.
Right, so temporary. And I imagine, as we've heard in Bronte's situation, we're reducing and deprescribing the medication, but increasing the non-pharmacological interventions at the same time.
Yes, yeah, and I think, again, that is dependent a little bit on the facility. I visit 10 different facilities at the moment and have ones that are absolutely incredible with their non-pharmacological methods and staffing, and then other ones which really are pretty appalling with it. And yeah, unfortunately, there is a direct relationship with how many antipsychotics they need to be on. But again, I think, as Bronte did, taking control of things and pushing for the residents' best interests is definitely a thing you need to do. Again, it's probably unfortunate, but a good thing to do.
Thank you. Now, again, conscious of time, but keen just to get some closing remarks from everybody. What would be, I think, from all of you, the take-home message for today for everybody who's on board and listening this afternoon? Bronte, I will just start with you. I'm very keen, your take-home messages for everybody, of course, but in addition to that, how did you acquire the knowledge and information that you needed in the end to best advocate for Glenda? Education, I think, is very important, not only for care partners, but also our clinicians, and that will be a conversation for another time. But how did you acquire the knowledge and information you needed to advocate for Glenda?
Okay, well, I'm not quite sure what the answer to that is. I've been around in dementia space for 15 years. So from when Glenda was first diagnosed in 2010, I've been a dementia advocate, and I've been on the board of Alzheimer's WA here in Perth for 3 of those years. So I kind of knew the landscape a fair bit. I knew a lot about perhaps dementia than other people might know. Care partners, those who are caring for someone with dementia. So I think it's a bit of a combination of, personal initiative and my background and experience. But I do want to say, on a note to finish up, that these non-pharmacological interventions that I described were pretty essential to my pushing through the development of the psychotropic standard, where there's reference to the behaviour support plans. I was a champion and an advocate for making sure that behaviour support plans were effective. I insisted on I think the word effective is actually in there, because too often I felt that they might have a behaviour support plan that was ineffective because there wasn't sufficient information collected about the resident. This is in residential aged care. So it's quite difficult, obviously, for care facilities to gather that information, but they really have to put an effort in and document as much as they can about the person. And, it goes to the heart of what we mean by person-centered care, to document what makes someone tick, so that they can then intervene when required in a non-pharmacological way when behaviour changes or becomes difficult to manage.
And I think the work that you did with the facility around the behaviour support plan for Glenda is really testament to that. And thank you so much for your work there. Just take-home messages from everyone, super quick, in about a sentence. Andrew?
I'm trying to come up with a short, snappy sentence that encompasses all the amazing stuff that we've discussed today. And I guess from a pharmacist perspective, it's all about understanding that medication treatment isn't necessarily lifelong, and making sure that, when we're discussing with either patients or those who are caring for them, that is the case, and setting that expectation early.
I think that's, a really good thing to leave everybody with, the fact that often the need for antipsychotic medications is short-term, and the need for reviews is, something that we need to keep front of mind. Alyssa?
I'd like to just empower everyone listening that if they're not sure why a person is on a medication, to ask, because people might not have realised that medication's still going, or they might not actually have thought about it, particularly for carers and family members, but for any member of the team. And if you're not satisfied with the answer, keep escalating it to the sort of next person up in the care team until you get a satisfactory answer.
Yeah, thank you. Another great take-home message, and empowering people to speak up if they're not sure about the medications that they're on. Really very good. Craig, last but not least.
I don't have much more to add. I'd agree with the, advocating and communicating. I think, as we heard earlier, lack of doctor communication. We're always around and happy to speak to people. But again, if you flag things with the doctor, particularly the GP in an aged care facility, we would always come back and speak to people. So definitely advocate.
Thank you. Vicky, I'm going to hand to you now to finish up for today's session.
Thanks, Sheridan. What a sterling job. And I have to say, just a fascinating conversation. And to you, Bronte, the main man, I just, full of awe. And, I know how hard the job is, being the care partner and for the length of that journey. So thank you very much. And I guess for me, listening, I'm always learn new things. And I loved, Andrew, that rational versus problematic polypharmacy and the balance between that. The GP involvement is key. Alyssa, you mentioned that. And I think what for me was kind of missing for Glenda was there didn't seem to be very regular involvement with the GP. So I feel like that might have been a little bit of a weakness in their journey. And those barriers to deprescribing that Andrew mentioned, largely just the fear and inertia, and not being afraid to speak up and challenge some of the authoritative voice. I think for the care partner and families as well, we tend to take, their advice as gold and, you know, follow it. And interesting, the pushback from families and sometimes clinical staff as well, that fear and inertia. The non-pharmacological interventions, I think that Bronte mentioned, and the behaviour support plan clearly were a game changer at the end when things post the crisis point. So that was, you know, obviously the best intervention for them. And I think underpinning all of this, it's all about communication that just comes through again and again, family involvement, you know, and communication across the multidisciplinary team. So I've just found it honestly fascinating, and I can't thank all of the panel members enough. So to Alyssa, Andrew, Bronte and Craig, heartfelt thanks. And to you, Sheridan, thank you for moderating. And to our Auslan interpreters as well, thank you for coming on board so late in the piece. So, and thank you to everyone who's joined us today, and we'll see you next time. Thank you.
Thanks, Vicky.
I'll stop recording now.